Now we have in line Dr. Sagar Bhargav, and I will introduce Dr. Sagar. So Dr. Sagar Bhargav is a senior consultant in the BBI Foundation, Kolkata, and director in the SLR Eye and Retina Surgeons Private Limited, Kolkata. He was the university topper in the first MBBS and won several awards. After finishing his MS, he joined Shankar Nethralaya, Chennai as a fellow and then the consultant, and he was recognized as the best associate consultant in 2008 in Shankar Nethralaya. Besides his clinical practice, he is now actively involved in various academic activities and has many presentations and publications to his credit. And I would like to invite Professor Tatyal and Dr. Sanjay Chaudhary to please be the expert panel for this presentation. Dr. Sagar. Sagar, I think you need to unmute yourself.
Yeah, is my screen visible? Am I audible?
Yeah, you are both.
Yeah, you are audible.
Yeah, thank you. At the outset, I would like to thank Dr. Partha Bishwas and AIS Scientific Committee for giving me this opportunity. It's a privilege. So the topic that I'm going to use is toric ICL. So as we know that toric ICL, the pre-ICL work has already been dealt with very nicely today. But I would just like to give some emphasis to the points which are relevant to toric ICL. The first very important point is that if the patient is a chronic contact lens user, it's preferable that patient should be off lenses for 2 weeks before you do the evaluation for these patients. You also need to do dry eye assessment, simple tests like Schirmer's, T-BUT, and corneal staining, just to make sure that this ocular surface issues are not changing or not affecting patient's refraction. A tomography would be required to just rule out subclinical keratoconus, and you need to correlate also the axis and magnitude of the cylinder. The fourth important point that we have to remember is that when you are putting toric ICL, we are actually treating the spectacle astigmatism and not the corneal astigmatism, as is the case in toric IOLs. Now, to explain this, let me give you an example. This is a 28-year-old high myope with who was using -10, never used any astigmatism correction, but see the retinoscopic value and see the keratometrics, a very high cylinder. Now, how has this happened? So, a topography would give you an answer for this. So, you can see a hot spot there, just superior to the center, and that was good enough for the instruments to pick up a cylinder, but it did not cause any effect on patient's refraction, and patient was just needing a spherical correction. So in this case, we just went in with a spherical ICL, and this hotspot was because of some subtle opacities which were present in the patient's cornea. So this is very important to remember, that you have to basically aim for a spectacle astigmatism correction rather than corneal astigmatism. Now, the next important point is marking. So marking is essentially just like a standard toric IOL, which all of us are absolutely used to doing, and use whatever the technique you are comfortable with, be it slit lamp, be it bubble marker, be it smartphone app, or be it digital marking. I, for one, usually use a smartphone app by Dr. Patwardhan, which is very convenient and very easy to use. And off late, because of availability of Varion at our center, I have now shifted to digital marking, which removes all the hassles, and it's very convenient. So let me share with you a case. This was a 36 to 35-year-old lady who came for an opinion for ICL, and this was the refraction of that. She was wearing a glass of -16 with 1.25 cylinder in right eye, and -11 with 1.5 cylinder at 180 degree in the left eye. The visual acuity was 6/24 and 8 and 6/9 and 6. And the first thing we advised was to discontinue contact lens for 2 weeks, and we called the patient again. And look at the refraction that has changed. Almost a 1 diopter increase in the sphere in the right eye, and cylinder also increased in the left eye. There was an increase in cylinder. We did a white to white measurement using Aladdin tool, which we have been using for last almost 4 years, and we find this quite convenient. It gives you both manual as automated as well as manual. Manual, if you feel that automated is not up to the mark, you can just adjust it and get the values. And this was how the topography looked like, an absolute regular astigmatism, and pupil size was also quite okay, and all the other measurement with the normal limits. So we started, we planned for an ICL for both the eyes, toric ICL. So this is how the lens power calculation sheet looks like. And when we take the patient in the OT, we have to use this, what is called as implantation orientation diagram, which is slightly different from an toric IOL. So here, the concept here is that the company people will tell you to kind of insert the lens with respect to the horizontal meridian. So it either you have to rotate it counterclockwise or clockwise, depending, and the degrees is what they will inform based on the calculation. So here there is a counterclockwise 16-degree rotation in which we need to implant the lens for the right eye. Now let's look at the video. So we just seen the various insertion techniques. So I have my own little modification of the insertion technique. I don't use the forceps at all. In fact, I just load the lens and do a very small nudges to just push the lens in. I've been using this technique for almost a couple of years, and I find this is very convenient for me because I always fear that pulling the lens out with the forceps, might tear it or something might happen. So that technique works for me. Just gentle nudges and just bring it to the tip, and then it's ready for implantation. So here we are just marking about 15 degrees, and this is the lens which is coming out now. And I use a iris spatula in the other hand, and just to make sure that there is a gap between the lens and the cornea, just to keep it away from the cornea. And the same iris spatula, you can actually push it in. You do whatever technique you are convenient with. But the idea is that you need just gently nudge the foot plates behind the iris, and the lens gets into the position. And the marks are there. So you basically need to now orient the marks, and we do it in the irrigation aspiration mode. And it's not very difficult to rotate these lenses. And the advantage here is that you don't need huge rotations. The rotations are usually between 10 degrees or 20 degrees. So it's a binomial method. You can just rotate the lens and bring it to the desired axis. So this was the endpoint. Here the issue here is that you should not allow the anterior chamber to collapse at the end. So just to make sure that everything is fine, and a little burp maybe just to make sure that it's not overinflated. And we did the other eye also of this patient, and we got a good result. It was a plano in 6.9 and 6. And this was the vault of the right eye around 524 microns. So I would conclude by saying that toric ICL definitely gives a very predictable outcome. Preoperative refraction is the most important thing. So a lot of due diligence should be given to preoperative refraction, and toric IOL marking technique should be mastered before you start doing toric ICLs. I think that's it. Thank you for your patient hearing.
Thank you, Dr. Sagar, for that wonderful presentation. I think you brought in very important key points for the toric ICLs. So now I would request Professor Tatiyal and Dr. Sanjay Chaudhary to please put in their expert comments. Yes, Dr. Chaudhary.
Okay. Yeah, okay. So the two things which are very notable in your presentation. One, the power of this eye was minus 17 with 2.5 cylinder, a minus cylinder. So if you have to transpose it, it becomes 19.5 with 2.5 cylinder plus, right? Now the question is, an ICL maximum power is 18. And so 18 spherical with a 2.5 cylinder is what you could have possibly used, because you didn't exactly mention what power you finally used. So the question now comes is that what should we correct? Should we correct more of the sphere, or should we correct more of the cylinder? Because every diopter of cylinder you correct is actually 50% of the spherical power which you would correct. So you have to come to a balance and still give the best effective outcome. What I normally tend to do is that if I would have a situation like this, I would leave, say, about 1 cylinder residual and aim for the maximum spherical correction, so that 1 cylinder is fairly acceptable by the patient and he gets the maximum advantage out of it. Because had I targeted a full sphere of minus 18 and I used an ICL of minus 18 sphere, the residual would have been 2.5 cylinder, which would have been very troublesome. And had I used a full 2.5 cylinder as correction, the residual would have been a spherical of almost 2, which the patient would not have been very happy about. So you have to strike a balance in between. So what did you exactly use as a power, Sagar, in this case, the final ICL power?
So the final ICL power that was recommended to us was minus 18 with a plus 2 cylinder at 100 degrees, sir.
Okay, so you're correcting more of the cylinder.
Yeah.
And effectively you would have less power on the spherical side, right?
Yeah.
Okay.
We were expecting some residual myopic error in this patient, but surprisingly, the patient we have been now following this patient for almost 6 months approximately. She has not accepting any myopic correction actually, and she is very comfortable with this plano. I mean, she absolutely refuses to accept any minus. We were expecting around -1 residual thing in this, but patient doesn't accept.
Okay. Now the second thing, which sometimes is very noticeable in these high powers, is the gain in visual acuity.
Yeah.
The gain in number of lines
Yeah.
that the patient would have in these high kind of numbers, especially when you're correcting the cylinder power, which is almost 2 that you corrected, with almost no cylindrical power left. So the patient started off with a vision of 6/9. So
No,
was there 6/12 in the right eye?
Yeah. So when patient came to us, patient was just 624, but it was an undercorrected refraction because patient was a chronic contact lens wearer. So we put the contact lens off for 2 weeks to get the exact refraction. So with the exact refraction, she did achieve 6/9 vision. So the
That
potential was there.
After the patient had a change in number, and you had a final refraction on which you ordered the ICL. What was the visual acuity at that level?
So that was 6/9, sir. It improved to
6/9 before the ICL.
Yes, sir.
Okay, so you could achieve 6/9 before the ICL.
Yes.
And then after the ICL, it was still 6/9, or was it
6/9?
Still?
No, it was 6/9, sir. 6/9.
Okay. Because a number of times it is noticed that most of the cases get a 1-line improvement, and many a times a 2-line improvement if you're not getting it on a spectacle correction.
Right.
So this is a real second big advantage of an ICL. So it is a high myopes where you in any case can't do a LASIK. For them, it is such a dramatic change in their life with an ICL that they just can't believe that something like this has happened to them in life.
Absolutely. And I have had some experience what you are saying exactly, that 6/18, 6/12 never had 6/9, 6/6 vision, and actually they turn out to be 6/9, 6/6 post ICU. So that really happens in some
I would request Dr. Tatyal sir to please put in your points, sir.
So first of all, I should say, Dr. Sagar, you passed the Viva exam very, very comfortably through Professor Sanjay Chaudhary. And you showed a very nice case also. As well as everything was very nicely highlighted. Congratulations for that. 1 or 2 points for a toric implantation, especially if you're using ICL lenses. Once you implant the lens, before you take out a viscoelastic, the lens has to be in a proper axis. Because after you remove the viscoelastic, then try to rotate the lens, very difficult. Then you have to use a bimanual technique to rotate the lens. It becomes very, very difficult. So for a beginner, I would suggest before you remove the viscoelastic, you must place your lens in an ideal position, then remove the viscoelastic if possible by bimanual technique so lens doesn't move. That's a very comfortable way of handling the toric ICLs in this scenario. If you're using an Indian lens, then you are in the right 0-180 axis, but ICLs, yes, you have to place in a different axis. Second important thing is, whenever we talk about procedure in a larger audience, which we'll be catering to, many of them will be beginners. So we should always give them a conventional technique first, then try to stress, okay, we can modify in our technique also. This is my take on, for our people here. You are experts. For people, we have to give a conventional technique for it. This is the right way which has been practiced. This is how I have modified my technique for my own advantage or for my patients. Otherwise, beautifully covered.
So my last question to you, Dr. Tiyal sir, if you have a rotation day one that you find for a toric ICL, when would you go in and how do you rectify that?
I'm sorry,
I mean,
you asking post-op
any tips
rotation?
yeah, post-op rotation in the ICL, sir.
Okay. I think there are 2 or 3 important issues there. If I have a patient who I feel the ICL may not be in proper place of your pre-designated axis, but if the visual acuity of patient is good, I'll not hamper go with the any intervention like we do for cataract surgery patients also. If the visual acuity is not proper, then yes, you have to rethink why this ICL has rotated. Then it will depend on your biometry or anatomy of eye and the ICL bolt at present examination. If the bolt is very shallow or bolt is very steep, then your assessment of your sizing was not correct. Then you have to rethink of your sizing and go for a new lens. If you feel your bolt is adequate, that is around 500 microns, then your rotation may have been because of viscoelastic retention, which could have changed their position, or your primary axis may not have been correct. He rightly pointed out if you use a image guided implantation, that will have a better axis orientation for your patient. So I would say if it will be basically either viscoelastic problem or a sizing problem. So both needs to be assessed. If it is a viscoelastic related problem, then you have to take the patient back again and maybe aspirate the viscoelastic and put the lens in the right orientation with the hydro procedure there. If it is a very shallow bolt or a steep bolt, then you have to exchange the lens.
I have a
Thank you.
small comment here, Dr. Sono. Dr. Sono, can I make a small comment here?
So looking to the paucity of time, we'll just give you 30 seconds. So please, a quick comment.
Thank you, Sonu.
Okay. So a quick one. Now, when you suspect that the lens has rotated or in the eye, is that when the patient's spectacle correction is still complete, but he is accepting what is a plus minus combination. That means a +1 and a -2 cylinder, or a +2 and a -4 cylinder, and getting a full vision, then you expect that the lens has moved in the eye. Now, when you see that, and then when you dilate and you check the parameters, you could collaborate that result. And then when it comes to correction, you have to see the vault, which usually is shallow in these cases. And the first impulse of an ICL surgeon is to bring the lens back in position and hope that it stays there. But we have some experience with these rotations, 4 cases so far. They all rotated. We brought them back, and 3 of them rotated back out of 4. So the impression is that even if you bring it back, there's a good chance that it will rotate again, and you would have to change to a size larger, and then they work.
So basically, undersizing was the basic cause.
Undersizing was the natural cause.
So thank you, sir. Thank you, sir. And thank you, Sagar. All to you, KP.
So no, just Dr. Parimal Desai wanted to make a small comment. He just raised his hand. Sir, unmute.
Yes, sir.
Unmute.
No, it was the same. The lens sometimes rotates. I had 2 incidences. One, I just found a girl. She came to me after 3 years of toric implantation, ICL implantation. We dilated the pupil and we could just set it. And other was the guy who just got it after a week, as he told us, as Sonu sir told us, that because I think ICL was small, we just replaced that thing and he was fine. So I wanted to just discuss that only, but he just asked him, and so now my problem is solved.
So one last question to Professor Titial. Sir, like I did one case, patient with the keratoconus, the right eye refraction with the stabilized keratoconus, patient aged around 35 years old. The right eye refraction was around -4 sphere with -4 cylinder. I did a toric ICL for that particular patient. Patient was absolutely all right for now. I operated 9 months before. His post-operative vision was around 612 parts with the keratoconus. Today he had come to me with the drop in the vision of 660 in that particular eye, right eye, and the refraction shows that +1 sphere with -5 cylinder at 51 degrees. So what is your opinion? How I should go ahead with this particular management, sir?
I think that's a clear-cut indication the ICL has rotated in this particular case, because all keratoconus eyes will have a very deep entry chamber, and the ICL sizing is going to be very challenging in these cases, because your actual lens position, lens rise is very difficult to assess in these cases. So I would suggest you have to reassess this patient with dilatation, see what is the peripheral bolt in these cases, because central bolt sometimes may not give a true picture in keratoconus eye. You have to look to peripheral bolt also. If you can't see through dilatation, maybe you have to do UVM to see exactly what's the position of ICL haptics in relation to the sulcus in these cases. So I would suggest, if this has happened, I'll always go for oversizing the ICL in these cases, and it may remain stable. But I'm not very sure in a keratoconus. Despite you oversize, sometimes they still can rotate.
Just a quick comment. I mean, it's very unlikely to rotate so many months after implantation. Usually you find the problem soon afterwards. I would definitely have a look at the topography also, just to make sure that it's not the keratoconus that's progressed. And if that's not the case, whatever Dr. Titial said is all valid.
Sir, I had a patient whose lens rotated after 1 year. My own cousin, high myo, his ICL was implanted, and after 1 year he came with sudden blurring of vision in one eye, and the history of trauma was there. Someone of his friend banged on his head.
Yeah, trauma is
He banged on his head, and the ICL rotated.
Trauma is one of the minor trauma also. I have had 2 patients, minor trauma and ICL haptics on the entry chamber.
And even when you break a sudden, when you're driving your car fast and you suddenly break it, suddenly you will have rotation. One eye was trauma, other eye was the car driving.
These are normally in the shallow bolts.
So we'll have the next presentation because already we are running short of time. KP, all to you, please.